And welcome to the third public consultation meeting of the Bermuda Health Plan. I acknowledge members of Parliament and senators who are here this evening. My name is Adoranka Batamosi Wilson, and I am your moderator for this evening's meeting. We have started promptly at 6:30, and we will end at about 7:45. We will watch a brief video, after which the Minister of Health, the Honorable Kim Wilson, JP, MP, will give a presentation. We will then have a question and answer period. Minister Wilson is accompanied by the Permanent Secretary for Health, Dr. Jennifer Attright Sterling, and the acting CEO for the Bermuda Health Council, Dr. Ricky Brathwaite, who they will all answer questions. And now, please be aware that this meeting is being streamed live on Bermuda. And now, the video.
Today, I, along with the government of Bermuda, look to continue the story of improving healthcare outcomes and making healthcare access a reality to all in Bermuda. Imagine a Bermuda in which all people can have access to the services that they require in order to stay healthy or to improve upon their health without suffering financial hardship. Imagine reading a story where we ensure that more people, more costs, and more services are all covered. So today, we embark upon the creation of a whole new affordable plan for better care and better healthcare outcomes. We look forward to writing these next chapters with you because this is our story, and I want us all to write these next chapters together. Good evening, ladies and gentlemen. Thank you very much for coming up this evening to hear more about the Bermuda Health Plan 2020. I have to hold this? Oh, goodness. Okay. Sorry. Good evening, everyone. Thank you very much for... Okay, let's start that. Third time's a charm. Good evening, everyone. Thank you for joining us as we talk more about the Bermuda Health Plan 2020. And the principal objective of this health plan is there's a number of objectives, but the primary objective is that we want to make sure that everyone can be healthier. And by that, we need to ensure that we have a plan that provides for more prevention, provides for access to health care for all. We want a decent core plan that has benefits to keep us healthy. We want to make sure that it is affordable and available to all. And in order to do that, we need to change the mechanisms that we've currently used insofar as how we finance it. And part of this goal, again, is to make Bermuda healthier through prevention and healthy living. Now, you've all heard the slogan and the jingle, healthy people in healthy communities, and that's what this is all about, making Bermuda healthier. But this slide just illustrates and demonstrates that there's other things that are referred to as social determinants of health. So our economic and social conditions can also impact our health. However, I've been charged as the Minister of Health to deal with the issue as it relates to the social determinants related specifically to health care. And that's what the Bermuda Health Plan 2020 seeks to address. I want to share with you some statistics because you'll hear me repeatedly say that we need to make Bermuda healthier. And unfortunately, we have some pretty dire statistics. There are some strengths in our system. Maternal and child health, we have 0 maternal deaths and low infant mortality rates. We have good immunization and outbreak control with respect to communicable diseases. Life expectancy in Bermuda is on par with other high-income earning OECD countries. And 98% of our adult population receive regular health checks. However, we have some sobering statistics. 75% of our adult population are either overweight or obese. We obviously have a challenge with respect to aging population. We have some long-term care challenges. We've got a society similar to other jurisdictions where people are living longer, and we have some challenges with respect to ensuring that we have care options and residential care options in particular for those individuals. 35% of all adults have a chronic disease, either diabetes, heart disease, or kidney disease. And regrettably, you and I and every other person in this island spends on average $11,336 per year on our health care costs. Our health care system does not get value for money. We are spending over $770 million a year on health care costs, which represents the third most expensive health care country utilizing health care costs in the OECD, but yet our life expectancy is only ranked at 13. So we're clearly not getting value for money. 11.5% of our GDP is consumed by healthcare costs. And you can see those are all the OECD countries, and unfortunately, Bermuda is leading the pack. In 2010, there was a study done, and they were reviewing our health spending, and they said that if we as a country don't take drastic measures, by 2017, we would have reached a $1 billion spend on our health care costs. And as such, from 2010 beginning, that was the beginning of the journey to try to address and arrest that by various measures, and you'll hear some of those measures this evening, so that we could avoid getting to that $1 billion cliff. So it's been very deliberate. There have been deliberate methods and incentives that have been rolled out since 2010 to try to avoid that. You heard me speak about our the unfortunate percentage, 75%, like I said, of our adult population are either overweight or obese. 54% of our adults have one or two chronic disease risk factors, such as smoking, low vegetable or fruit intake, inactivity, either overweight, you've heard me speak about just a moment ago, or raised blood pressure. So 54% of our adult population have one or two chronic disease risk factors. 12% of our adults have diabetes. $78 million per year is spent on two preventable diseases, preventable conditions. So 10% of our overall spending is spent on two things that are preventable. You've heard me speak about the long-term care challenges that we have. We have an increasingly aging population. We have declining birth rates and less people that are working to help to sustain us. So that is another one of the challenges that we're currently facing in our system. 20% of our population are either underinsured or uninsured. So if you took Devonshire and Smiths collectively, the area in the middle in the red, that would represent all persons in our country that are either uninsured or underinsured. So as I spoke about a few moments ago, in order to improve our health and make health care more affordable and available to all, we have to change the way that we pay for it. We need to create systemic changes so that we can incentivize good health behaviors and receive better health outcomes. So back in 2010, there was the National Health Plan had a task force called Health Financing Task Force. And that group was contracted actuaries as well, and you can see the composition of the group is there, and it was the Financing and Reimbursement Task Group. And they actually worked with Professor Mark Roberts, who is a Harvard professor, an advisor to this task force to help them to look at various options for how we can pay for our healthcare system. And when this group, this group started meeting in 2010, and they looked at two particular health financing options. And the mandate that they were given, we said to them, when you look at health financing options, we want you to look at options that will best suit Bermuda's needs as it relates to improving efficiency, sustainability, and healthcare access. So following consultations, the government decided, and it was announced in August, at the beginning of August, that we would have selected the unified model for health financing. This health task group that I just spoke about, they looked at two options. One was dual and one was unified. Last fall, we had a stakeholders consultation group review the options document that the group of 2010 that I spoke about. That was produced in, the options report is actually on our website. However, they reviewed it, and we had a stakeholders consultation group that was made up of members of the medical fraternity, charitable arm, the unions, seniors representatives, IB, insurance companies. And they looked at those two options, and we invited them to consult with their respective constituency bodies to come back and say which option did they think would be best suited for Bermuda, recognizing that we wanted to ensure efficiency, sustainability, and ensure that we had access to health care to all. And following the review of that document, as well as the options report, as I said, the government selected the unified model. So, what are we consulting on? There's a couple of things that the consultation period will involve a number of things. One is the roadmap. So we're consulting on how we're going to transition from the existing model that we have to the unified model. And that consultation period has started. It started several months ago, actually, and there's been a lot of stakeholder engagement, again, with all the persons relevant to this particular transition, because we know that we can't just flip a switch and that tomorrow we will have a unified system of health financing. We recognize that that's not going to happen. But what we need is our stakeholders at the table to assist in developing the roadmap as to how we transition to a unified system. Now, it may take a year, 2 years, 5 years. That's what part of the roadmap development is taking into consideration. What aspects need to be dealt with first? What's second? And that's part of the roadmap. This slide just illustrates what I've just spoken about insofar as we have the Health Financing Reform Steering Group, which I spoke about, that was formed in July of 2018. Then we had the Financing Options Stakeholder Consultation Group. We've had pre-consultations, and we're in the yellow region right there, which is the public consultation period. That started in August, and it will conclude in December. That's with respect to the public consultation. Consultation is ongoing with the other principal stakeholders, like I said, the physicians, the medical community, insurance companies, employers, unions. That consultation will continue because they will be helping us to drive the roadmap as it relates to the implementation to the unified system. We are looking to synthesize all of the information that we gathered during the consultation in the spring of 2020 with a launch in autumn 2020. And that is a soft launch because, again, subject to the results of the consultation, we will not be rolling out a unified plan for all 68,000 residents of Bermuda in August 2020. We know it has to be a phased-in approach, and how that approach, or which areas are going to be phased in first, second, third, 10th, is what the consultation process, particularly as it relates to the development of the roadmap, that is the objective and the purpose. So we need to have a sustainable platform for a patient-centered care model so that we can help to improve health outcomes. We need a decent core plan that will help to provide us with benefits to keep us healthy. Additional benefits will always need to be made available through private insurance. So the private insurance companies, there will still be a need for them to offer supplemental benefits. This is part of a broader reforms that will also address other drivers of health costs, such as the fee levels, co-pays, utilization as well. But it's also part of the broader commitment to make Bermuda healthier through prevention and healthy living. So what are we consulting on? I've already spoken to you about item number 2 with respect to the transition to the roadmap with respect to the unified health financing system. But what we also need to hear from members of the public is, what would the new core insurance plan, what should it include, and what should be the cost point? So when I say what it should include, and we have some flyers over there on the corner, but all of this information is available on the website as well. But we want to hear from members of the public what benefits should be included in this core package, because this core package will replace the existing standard health benefit. So right now, as required under the law, every insurance policy holder a portion of that insurance must include what's referred to as the standard health benefit. And that standard health benefit, which is $355.31, is 95% of that is simply for inpatient and outpatient care. It has very, very little preventative measures in it. There's a little bit of diagnostic imaging. But that particular standard health benefit, which again is part of everyone's insurance as required by law, will be replaced with the Bermuda Health Plan. What will be included in the Bermuda Health Plan and what benefits will be included is what the consultation process is all about. This core insurance plan needs to include more prevention. Like I said, the existing standard health benefit, the majority of it, 95% of it, is for inpatient and outpatient care. However, the World Health Organization has said if you want to have a proper core plan that's made accessible to your citizens, it must include preventive measures, primary care. And as well, the plan will also include coverage for serious health instances, so for overseas treatment that's medically necessary that's not available in Bermuda. So we have developed a mock plan, and again, we've got flyers, or you can see a copy of it in the consultation document or on the website. And this mock plan has been developed so that we can start the conversation and start the discussions. And again, the part of the consultation, the principal part of this part of the consultation is to hear from members of the public what they want that core plan to look like, what type of benefits should be included. The consultation plan, the mock plan that has been developed, includes prescription drug coverage. So for example, what's been modeled, and I think it's $514, includes a $400 prescription drug benefit per annum. Now we've already heard, because we've been having these consultations for several months now, that $400 is insufficient. If you have a chronic disease, we know that $400 will not be sufficient. But that's the feedback that we're hearing, and that's why it's important for us to hear your feedback and to have these type of sessions. If you are a person that's on HIP, which is the government health insurance, which is the most cost-effective health insurance, it doesn't even include any prescription drug coverage. So we've added to this particular mock plan $400, but again, we understand from our consultation heretofore that that is not sufficient if you have a chronic disease. Primary care, we're looking at a capitated model. We're in discussions now with the medical community. These discussions started some time ago, and they are ongoing. So even though the public-faced portion of the consultation ends in December, we will continue the dialogue with stakeholders in the medical community, the employers, as well as the insurance companies and the like. Enhanced care program, we need to make sure that we have a benefit package that allows for disease management, chronic disease management, because you saw the sobering statistics that I started the presentation with respect to the instances of chronic disease in Bermuda. We're looking at specialist care as well, access to specialist care with capped copays, and I'll talk about that in a moment. Personal home care benefit, which has proven very, very popular to persons that require individual assistance with their loved ones who are either disabled or senior citizens of our community. Basic dental and vision, as well as basic overseas care, which I spoke about for medically necessary treatment that's not available in Bermuda. This is a sample of the Bermuda Health Plan 2020 by comparison. So you can see what the current SHB, the draft BHB plan, measured with HIP and measured with future care. And the next slide is just another illustration of the comparisons of those four plans. And this is another comparison for an adult, a single person who is on existing HIP. HIP is $429 a month. And then if you see on the bottom underneath on the green side, the Bermuda Health Plan 2020 has been costed out at $514. However, you have to also look at the savings insofar as, again, under HIP, you would get no coverage for medication. In the Bermuda Health Plan, you would. Under HIP, a copay is not regulated. So you could go to one doctor and be charged one amount, and somebody else can go to that same doctor, and that copay could vary. They are not regulated. And likewise, with respect to the copays for specialist visits. What this plan is envisioning is that whatever benefits are under the core plan, the fee associated with that particular procedure and the copay associated with that particular procedure will be regulated. So, for example, if a physician has 10,000 procedures that they perform on any given year for their patients, and only 20 of those procedures are coming under the Bermuda Health Plan, those 20 procedures, the fee for those will be regulated and the copay associated with that will be regulated. So a couple questions that have been coming up. Like I said, we've been doing these, having these meetings for quite some time, and this is a couple of the questions that we've seen a trend, so I thought I'd add that here because it may be some questions that some of you in the audience may also be thinking and wondering. Why don't we just provide services for the poor and the uninsured? Why don't we just pool them all together? If you're poor or if you're uninsured, you go over there in this pool, and then the rest of us are going to be somewhere else or have what we have in the existing pools. Well, not only does that marginalize the poor and by creating a second-class citizenship, but also it's far more expensive because we don't have the benefit of having the risk pooling. So, for example, if you are employed and there are 10 people that work within your group of employment, and you're insured at company ABC. If one of those persons has an illness that requires extensive treatment, the other 9 people are going to share in the costs associated with that one person because you're risk pooling. When you have a bigger pool, such as 68,000 people, as you'll see in a unified system, then if one person or 10 people or 100 people have that similar illness, the risks are shared amongst the 68,000 people, so therefore, because of the economies of scale, so to speak, you're not going to see these drastic increases in your insurance coverage. Will employers reduce coverage with a better core plan? Well, we're seeing that now. There's already a risk of that, where some employers are saying, I'm going to offer my employees HIP as opposed to major medical, or the minute their employee goes 65 and they're still employed there, then they offer them future care. We're seeing that now. And of course, we'll continue to monitor that. But if that's happening now, we're not anticipating that it's going to happen in greater numbers by the introduction of a better plan, the Bermuda Health Plan. And likewise, with respect to the existing plan, like I said, it's minimal. HIP doesn't even include medication. So HIP is brilliant if you're healthy and fit and you have no medical conditions. But if you're on HIP and you have a chronic disease, you have no medical coverage, and you are underinsured effectively, and you do not have sufficient coverage to meet your needs. I should pause really quickly, because what's anticipated for the Bermuda Health Plan 2020 is to meet everyone's needs. Not what they want, but what they need. And we know that we need to see more prevention, more monies with respect to prescription drug coverage and the like. But it doesn't mean that we're going to be able to provide for everybody what they want. Our main objective is to provide the needs, the core fundamental needs of what persons need. And the goal, again, is to ensure that there's good core coverage for everyone. All right, some more questions that have come up. Who will administer the plan? That decision hasn't been made yet, right? We recognize that we have to find a provider to administer the unified plan, whether or not it is a government quango, whether or not it is an RFP process where one of the insurance companies bids on that. The decision hasn't been made. Again, that's part of the consultation, but that decision hasn't been made. Will costs be available to the public? Yes, I'm sorry. That information relates to the modeling assumptions. So, for example, the benefit plan that's already been modeled for the mock discussion, the 514 plan, the assumptions and the analysis as to how we got to that number, that information is already available on the on the Bermuda, on the health plan website. So that information is already available for the public to review. How will the copays be capped? Again, the procedures that are offered by the physicians that come under the Health Plan 2020, Bermuda Plan 2020, those copays will be capped. What that figure is, we're still in discussions about that now, but the copay will be capped. Will mental health care coverage also be covered? Well, right now it is obviously part of Mid-Atlantic Wellness Center, so that will continue, but we recognize that services like counseling and psychiatrists and so forth, we're hearing from members of the community that there's a need for that. So those are things that we're also looking at to be included in the plan. How will people who can't afford it be covered? Well, that is an issue, and at this point we're looking at there will be a continuation of financial assistance, so if individuals do not have the means because of their own circumstances to be able to pay for the Bermuda Health Plan, then there will be the available option of them receiving financial assistance to help pay for that, and as well, moving forward, we'll be looking at subsidies. Will there be health information technology for the plan? Absolutely. We recognize moving forward in this century, everything is about technology-based, so we're looking to include telemedicine as well as electronic health records. So those are all things that we recognize are necessary and that we would be looking to include. We need to create fiscal space to address prevention, chronic diseases, fee levels, and utilization. And in order to do that, we're going to be looking to improve prevention and primary care coverage, have more chronic disease management, control co-payments, regulate prescription drug prices and dispensing fees, reduce unnecessary utilization, address conflict of interest in health services, retain choice in insurance and supplemental benefits and elective health care, as well as to create financial incentives for health maintenance. So the next steps are, like I said, the consultation period, and that's where we are engaging members of the public to help us to establish what should be in that core benefit package and what's the cost point that we should be considering, and also the establishment of the roadmap to help transition from the existing model to the unified model. And in closing, this is all about making Bermuda healthier. We agree that everyone deserves access to health care and prevention, and we want to make sure that that said health care is affordable. So in closing, this is what we were asking for your assistance in. What should the benefit plan look like? What should those benefits include? What is an affordable premium? And what do you believe is a reasonable copay? And we would invite you to take a copy of the consultation document or go online and provide your input, because this is critical, and this is going to be a plan that's going to be offered to every one of us. Thank you very much.
Thank you very much, Minister. We will now take questions from the audience. As I mentioned earlier, we will be ending at about 7:45. If you have a question or comment, please come to the microphone, which is in the middle of the aisle right here. And given that there are a lot of people here today, we want to hear as many voices as possible. So we'll limit each person to 2 minutes. If you have a question or a comment, please make your question or comment within 2 minutes, and I'll be the timekeeper. If you do not wish to come to the microphone but have a question, my colleague right here will bring you a card and a pen. Please write clearly, because I'm the one that actually has to read your question so the panel can answer. And so please, let's start the questions.
Do you have any thought on how much you're going to allocate for overseas patients that have to go overseas for healthcare? Is that going to be also capped, as it were?
That figure, that percentage hasn't been determined yet, but I'll lead to the person to my left, actually, who has all that transactional level data. However, what the intention is that if it is a medically necessary procedure, that cannot be done in Bermuda, then that will be covered in this plan, because we recognize we can't do everything in Bermuda, but on this other hand, if it's medically necessary, and in fact, we had a meeting, and Dr. Braithwaite will speak about that in a few moments, because we are having ongoing discussions at the Health Council, and one of the ones that they recently had is, what does it mean to have medically necessary treatment? What does that mean? Does it mean that somebody can have augmentation? No, not necessarily, because that may not necessarily be medically necessary. But if it's necessary and it's not available in Bermuda, ma'am, it will be included in the plan.
So good evening, everyone. So we actually had a good conversation about that with some of the physicians and other stakeholders actually this morning. And we talked about that exact question on overseas care coverage. The intent of the Bermuda Health Plan is to cover anything that is, as the minister mentioned, anything that is not available on island as medically necessary. One of the things that the physicians spoke of was the difficulty they have about this gray area of determining what is medically necessary. And so we understand that the physicians are the ones that ultimately are going to have to make that decision. We talked about a medical review panel, which will be part of that decision-making process. Currently, we're spending about $90 million a year on overseas care. Whatever proportion that is determined to be medically necessary out of that spend is being looked at as to be covered under the Bermuda Health Plan. Right? So it is very clear, both physicians, insurers, the Health Council, and so forth, we all understand that some of the care that's being delivered overseas cannot be defined as medically necessary. So there is a proportion of care that is taking place that is not medically necessary overseas. And so that has been confirmed by multiple sources. So when you talk about medically necessary, and I don't mean to go too much into it, so something like a dermatology visit because you have a preference for a dermatologist overseas, part of that is actually being done overseas. When we talk about what is medically necessary, we're talking about things that are not those kind of elective procedures, but we're talking about urgent situations, emergency care, air evacuations, those kind of things that are actually referred by specialists for you to be seen overseas for. So it was good to have one of the neurologists in the room today to talk about their perspective on that this morning. The notes for that meeting will be online, so if you want further information as to what was discussed during that meeting, those meeting notes should be online maybe tomorrow. So there's a schedule, so we're having community discussions on various topics Tuesday, Thursdays, and Fridays, every Tuesday, Thursday, and Friday. The notes can be found, you can find a link on the Bermuda Health Council website, www.b as in boy, H as in Harry, E as in Ernest, C as in cat, Charlie. I wasn't in the military, so I'm not very, .bm. So bhec.bm. You can find a list of the schedule of discussions and the notes and the briefs that go along with it. But it's a very interesting discussion around overseas care.
Let me add something. I'm looking at your face, and I'm thinking that we've talked a lot and we haven't answered your question, quite possibly. Yeah, exactly. So how much is going to be offered, whether we say, okay, we're going to pay for 75% of it, and you will have to pay for 25% of the balance. That hasn't been determined yet, right? The discussions on the ultimate content of the plan are what will lead us to those conclusions, which is why we're talking about, should there be copays, at what level what kind of copay should there be, what is affordable to the country. So ideally, we would like to end in a situation where medically necessary care that has to be exported overseas, that we can help people to cover as much of it as possible. Now, will we include the airline? Will we include air evacuation? Will we include a hotel stay? Will we include a support person? That depends on how much the plan can afford. Right now, we have budgeted $40 million. That's what's included in this mock plan. Now, what can we buy for $40 million? That needs a lot more work. But we certainly, the intent would be not to leave people out of pocket for care that is absolutely necessary, right? So we can't tell you a cap, or whether there would be a cap at this stage right now, but our intent is to ease the burden on people, unlike, say, HIP right now covers only 60%, and future care covers 75% of overseas care. Yeah, we hope to be able to do something better than that. Yeah.
Once you've used your 40 billion, then what about patients coming after that?
40 million is just what has been accounted for in the modeling right now, but that is adjusted on an ongoing basis. It may be that with the consultation we'll say, you know what, we don't need 40 million, 30 million will get us the necessary care that Bermuda needs, or it may be at 50 million. There's a lot of discussion that has to happen still.
Okay. Next question.
Hi. Thanks for this opportunity. It's great to hear the presentation and get some facts. I just have a question about logistics, really, because you're inviting us to consult on the plan, and one of the primary ways, from what I can see, is online. However, I did try to do that today, and it's not functioning. So literally, there's no way to comment on those two questions that you presented. So, you know, it's also feedback that I've heard from others that it's been a bit of an ongoing thing in the last 2 months. Mm-hmm. So I think that's probably a really important part of gathering public opinion.
Okay, we'll have to check the website if something is not working, because the query should be directed to an email address, healthplan@gov.bm. And that's what we've put on all of the documents, to give the feedback to healthplan@gov.bm. We have received some queries. The ones that arrived this week have not been answered, so if your query is in this week's batch, I'm sorry, the answer will be forthcoming though. But that's where all of the feedback is intended to be received.
So there's also a function online that suggests that you can put, there's 2 or 3 comments there already, and that area now is closed. So email is one way, but then you don't see what other people are commenting on, and there's no dialogue or two-way consultation.
That's right. There was I thought that had been taken down already. There was an administrative error, and that blog function was put up accidentally. It should not have been put up in the first place, because all of the feedback is to go to healthplan@gov.bm, not on the blog. So those individual submissions that have been made on the blog are being responded to individually, but we want everything to end up on the inbox so that we have everything in one place.
Okay, but then someone won't see what my opinion is.
Well, we will publish.
But I want to see what other people's.
We will publish all of the feedback, right? In the consultation guide, it stipulates clearly that we are going to publish all of the feedback. And we've said to people, if you want to provide feedback that you feel is sensitive or confidential, put that in an annex and tell us why, and we will withhold that from publication. But we will put all of the feedback that we receive online.
Okay. That will happen at the end of the consultation.
At the end of the consultation, that's right. The consultation guide makes that commitment.
Thank you.
Okay.
I appreciate that.
Yeah, sorry about the glitch.
No, okay. Okay. She said it's difficult to hear. All right. Thank you. Go ahead.
Good evening. I have a few questions. I'm only going to ask 2. So of the 20% of the population that's underinsured and uninsured, how many of them are of working age?
Is that...
That's one of... I have 2 questions.
Sorry. Both at the same time.
Oh, sorry. And so I work in the dental field, and with the numbers and stuff that we're giving, it just seems like the numbers aren't feasible. So for me, I see 3 outcomes. I either lose my job because the practice isn't making enough money to pay me. I'm employed, but I have a pay cut, and then obviously I can't afford my bills and rent and everything else. Or I'm fully employed and I have my pay, but I'm now seeing 20, 25 patients a day as opposed to what I'm seeing now. So my workload doubles. I'll be worn out in 5 years. I'm young. I still have 30 years, 35 years work left in me, but I won't be able to do that if I'm seeing 25 patients a day.
Thank you.
Okay, I'll start with the second question first, and then I know one of them has the data, because I just know the number is 20%.
It's in the census.
Oh,
The
okay.
breakdown is from the census.
Okay, the breakdown is in the census, actually, as to what percentage of the, I don't know if you heard the question. The question was, the census data supports that there are 20% of our population is either underinsured or uninsured. And the question is, what does that represent insofar as age?
Like the
and,
working population.
right, and the working population, exactly,
Of
exactly.
working age.
So the answer is actually that information is in the census data. So you'll be able to look at the census and it will show you the breakdown and the,
Yeah, we don't have it here.
Okay.
but it's on the census data. And then, secondly, with respect to the dental coverage and your concerns about a pay cut, et cetera, and I appreciate your concerns and thank you for that. At this point, what's being envisioned is that only certain services that are offered by the dentist will be covered under this plan. So not everything. So I'm not sure if you heard my example. So for example, if your practice, you offer 2,000 services, right? And they range from,
Like a cleaning.
right, a cleaning to whatever, exactly.
Extensive work.
Precisely, but those 2,000 services will not all fall under the Bermuda Health Plan. Only the ones that, following consultation, and it may very well be cleaning. The consultation period might reveal that the public just want to be able to have their teeth cleaned twice a year. Those services, those two services, will have a capped payment as well as a capped copay. All the other 1,998 services will not be affected. It's only the services that form part of the core basic plan for the health plan. So just those services.
So the health plan will still provide coverage for those other services?
No, not the health plan, but there will always be a need for supplemental insurance. So for example, let's say at the end of this exercise, it's decided that, based on the public consultation and the feedback, that they would like to have 2 hygienist visits a year. That is the dental provision. So 2, but if in addition I want to have braces or whatever other things that my dentist can provide for me, I will have to get my own supplemental insurance. Like I said, this plan is designed to provide the core benefits, not what everybody wants, but what we need. And hygienist visits, following consultation, will likely be what people are saying, is I would like to have hygienist visits, right? But the fact that I want to have Invisalign isn't necessarily going to be covered. I can buy supplemental insurance for that.
Thank you.
Did you want to add? Okay. Thank you.
Good evening. I'd like to ask a question with regards to employers. Right now, we all have employment contracts which clearly state that we have medical benefits, whether we have HIP or we have medical benefits. But now, listening to this, we're going to have the Bermuda Health Plan, which is going to be 1. There's going to be a need for supplemental benefits, which is going to be 2. So are you saying that this is going to make all the employment contracts that we currently have null and void, because the employers can no longer fulfill their employment contracts because they can no longer offer HIP because it doesn't exist. They can no longer offer comprehensive medical insurance because it no longer exists. So what guidance are you giving employers with regards, I mean, do we have to fire everybody and renegotiate all the employment contracts? What about companies that already have overseas insurance that are working in Bermuda? What will they do? Because they, I just don't understand from an employer point of view how, and a legal point of view, how this is going to be dealt with regard to employment contracts.
Okay, thank you. Thank you for that question. The plan itself, under the legislation now, if you have, everybody that has a insurance plan must include an element under the standard health benefit. So your insurance packet has to include the standard health benefit. This Bermuda Health Plan will replace the standard health benefit. So again, there still will be a need for supplemental insurance, but this is only a replacement of what is required in law now under the standard health benefit. So we're swapping out the standard health benefit for the Bermuda Health Plan.
Yeah, but that doesn't cover comprehensive insurance. If your employment contract says comprehensive insurance, now what we're going to need is the Bermuda Health Plan plus supplemental coverage. So you're going to have to redo employment contracts for every employee. Their employment contracts may be null and void.
That's not quite right, and part of the consultation process is precisely this issue of developing a roadmap of how are we going to transition from the current system to a unified system, right? So much of the detail of how that's going to be faced hasn't been worked out, and we're going to do it with employers at the table. Employers and insurers are key in developing that roadmap, and so we don't have all the answers now. But, as the Minister said, what is clear now is that the employers are required by law to provide a minimum level of insurance. Employers are not prohibited from providing additional insurance. In the future, employers will be required to provide a minimum level of insurance, and they will not be prohibited from providing additional insurance. So in that sense, those principles are not going to change. And an employer's willingness to provide supplemental benefits, as 80% do currently, is not going to be changed by this change in model. It isn't affected in terms of what an employer's willingness is or what an employer's obligation is. But there is a lot of detail to work out, absolutely. Yeah. Yeah.
Okay, so I'm just going to, okay, so I'm just going to take a question from the floor. Thank you. I'm just going to take a question from the floor. Has there been any research into what impact the Bermuda Health Plan will have on access to health services? So, for example, wait times to see your family doctor or a physio at the hospital or have an operation locally. And the second question? Can we take one at a time? Okay, sure.
So has there been specific research on what increasing access to some of the services within the Bermuda Health Plan will have on like wait times? So wait times are dependent on a number of different factors. So just increasing the benefits that you have does not have a direct correlation with wait times. So I don't know if we can answer that question in a comprehensive way. If the doctors will no longer be here because they're upset about not having the patient quota that they will have. So right. I can't speak to the doctors being here or not. Right.
I can answer that question. Is that we'll lose half the doctors. Everyone on work permits here will leave. Don't be mistaken. People are not, doctors are not here because they come here for charity to Bermuda. When they expats here on work permits, they come here because they make a good living and they're doing better than they do in their own country. If that's not the case anymore, they will leave. So that's the simple answer.
So in 2008, the Pan American...
Not enough.
In 2008, the Pan American Health Organization came to Bermuda and did a detailed study on our healthcare workforce. And they looked not just at physicians, but all aspects in different professions. And they established, and the report is online, that we have a very good ratio, a very favorable ratio of physicians per capita compared to other countries, in particular the ones that are close to us, Canada, the States, the UK. We have more GPs per capita than the US does. So, of course, if changes occur that cause the sector to pick up and leave the country, well, that would be a problem. Of course, that would create queues. However, where there is a gap, gaps can be filled, and other people can come and fill those gaps. So,
what quality doctors are you going to get then?
So the question that was on the card, which I don't know if it's a question that you are posing or the question that you're posing, Doctor, but if there has not been a study on what would happen to the wait times if Bermuda's 200 doctors left the island, that we have not studied that at all. We have studied what our health workforce capacity is now and whether it suffices, and the answer is yes. We also have not concluded the discussions with the doctors about what is going to be included, how much of their services is going to be included, what those services are going to be reimbursed at, whether they're going to be capitated, whether they're going to be paid fee for service. All of those conversations are nowhere near finishing. There's a lot more discussion to be had. So it would be really premature to assume that that is a done deal. There is, to walk away from the table and to run away from the country before decisions are made and the plan is finished, well, it seems foolhardy. There is still a lot of work to determine before people decide to shut their doors.
The second question. Is there a cap on inflation increases, or is there a real possibility we could see significant increases as a result of a bad estimate of the fee? Significant will be an in excess of 5% per annum.
So any modeling of any premiums will go through robust actuarial modeling like any other premiums do. So just like any insurance company does actuarial modeling on their insurance premiums under the Bermuda Health Plan will go through the same comprehensive, robust modeling as we do every year regarding the standard premium rate.
All right, thank you, sir. You have 2 minutes.
Hi, Dr. Boots. I'm one of the GPs in the island. You basically want pay a system and currently there are only 33,000 people paying into the health system in Bermuda. How are you going, with insurance companies, international companies here, how you cannot force them or legislate them to pay into this health, this $514 basic health care plan? A lot of them already. I've got patients who have insurance in France and in Germany, in the States, who have comprehensive insurance, and they pay us cash. We give them a receipt, and they go and claim from their insurance. So, and there are other companies, and I've actually investigated one of the companies who will insure expats on the island for a lot less than $514 a month. Comprehensive insurance. So your plan is based on at least 10,000 expats on the island contributing to your pool. They don't have to contribute pool. And if you're going to force them to contribute pool, and a company like AXA, a big company with 300 people, they're going to go, hang on, I'm not paying $500 there. I can pay $500 in France for comprehensive insurance. The people will be covered on the island, and they'll have travel insurance. And no one speaks about travel insurance, so the basic health plan is not going to have travel insurance. So you need to have insurance to cover everything to a point where you have now with comprehensive insurance, and then you need travel insurance on top of that. So I don't see how your plan with a one-payer system is going to work with 10,000 or
20 seconds.
It used to be 15,000 expats on the island. It might be down now to 10,000, but those are 10,000 people that are not going to pay into your plan, and they shouldn't be forced to pay into it. Otherwise, they'll leave, and then we're all screwed.
So there are 48,000. So there are at least 48,000 people who are currently contributing to the health insurance market.
Can we just have one person talking at a time, please?
There are 48,000 people who currently contribute to the health insurance market now. We went over these numbers actually today. At least 48,000, because that doesn't include any payments made for children, right? So 48,000 is the minimum number. In terms of employers using out-of-country insurance companies to cover their employees without buying at least the standard health benefit, that is illegal. So I understand that there may be some of that going on, but it's actually illegal.
Thank you. Good evening, everybody. I just have a question, and that is, with the exhibit that is showing on the website, and copies of which have been made available, that's the blue and white exhibit, there is a side-by-side comparison to the Bermuda Health Plan, HIP, and Future Care. presently obtains and how the three compare. The indication initially was that people would have the Bermuda Health Plan, and this is what you would have if you don't have HIP, if you don't have Future Care, with the assumption that both HIP and Future Care were going to go away. It has now been made clear that HIP and Future Care are not going to go away. They will remain as individual plans, and the rest of the community will be then put into this community-rated standard Bermuda Health Plan. We're just trying to clarify, because under the existing exhibit, if you look at the comparison, it says that, I asked this question before, and I think you did answer the question, that under Bermuda Health Plan there'd be $400 worth of prescription benefits. Under Future Care there'd be $2,000. You indicated that under Future Care clients would actually have $2,400, which is what you said at the meeting in Somerset. So I'm just trying to clarify whether Future Care will exist in the way it does now, whether HIP will exist in the way it does now, and their standard health plan becomes different. And then the second question that I have is
20 seconds.
Of the existing premiums, there is a required contribution, the $355 that goes into what's now the standard health benefit. The question is, will Future Care and HIP premiums require payment into the Bermuda Health Plan so that there is a smoothing of the benefit, or is this just a shifting of the government requirement to smooth out their loss ratio?
So currently within every health insurance product, including HIP, Future Care, GHI, all health insurance products, you're required to have standard health benefit. The price for standard health benefit is $355.31. Don't quote me on the 31 cents, but I'm pretty sure it's 31 cents. Everyone who has health insurance is required to pay $355.31. A major portion of that money is now being transferred over through the MRF to pay for hospital care. So that's currently happening. The Bermuda Health Plan is an expansion of the standard health benefit. So if you're currently required to spend or to contribute $355 of your health insurance premium by law to the standard premium rate, what we're saying now is we're looking to expand the standard premium or standard health benefit into a more protective health insurance product that forms the building blocks of the healthcare insurance coverage that everyone will have. In terms of Future Care, we talked about prescription drugs, the $2,000. Within Future Care now, as I mentioned, there is the standard health benefit requirement. So $355 is included in your Future Care package now. So if you look at Future Care's, the cost of Future Care now, what it doesn't require is a mandated minimum of drug coverage. The $400 is just mandating that there's a minimum amount of drug coverage within your insurance that you would buy. It does not take away the ability for Future Care to have a coverage of $2,000. What it just says is that there has to be at least $400 included in anyone who has health insurance. Right now, that mandated minimum is $0. So if any insurance company today wanted to say we're not going to cover prescription drugs anymore, they actually by law could.
I'm going to try to answer it in less words, because you started out by saying that the health plan will exist alongside HIP and Future Care. I think it's really important to understand that the health plan will replace the standard health benefit. So the standard health benefit is inside HIP and it's inside Future Care and it's inside every other insurance package. The Bermuda Health Plan will be inside HIP, inside Future Care, and so on, right? Now, it is right now the MOG plan has benefits that are more generous than HIP. In such a case, HIP would, if that's where we settled on, HIP would cease to exist, right? HIP would go away. It would be redundant because the basic is more than what HIP is. But Future Care would continue to exist. If the consultation results in people saying, no, we want a really generous plan, and it exceeds future care, then future care would become redundant too, because the basic plan would become the core, or the core plan would be the most basic plan available. Yeah? Your second question was, will HIP and future care contribute to the plan? If the core plan ends up to be less, just like HIP and future care do contribute now, they would continue to.
Good evening. I'm hearing that you mentioned about the legalities of getting other type of insurance, which means that this is basically what we've become is socialized medicine you're putting on the table. You're saying that the government now is mandating us to have only their insurance, and there will be no other insurance beyond what will be considered supplemental. But you also say that you're going to include what's necessary, but then you say you're going to ask us what's necessary. So if people want extra stuff, then the extra stuff will therefore become the necessary component. So it's going to affect what's considered to be a reasonably cost plan if we start adding all this stuff in to raise the cost of it. Whereas right now you said you don't want to take care of just the underinsured or the uninsured because you don't want to marginalize them, but if they can't afford what they have now, you're going to marginalize them because they're going to have to get financial assistance to build into what you're building now. So you once again marginalize the people who cannot afford it. Today I had to take care of people whose $2,000 in future care has already gone and it's not even halfway through. Today I've had to take care of somebody who has GHI who can't go away because they have to find some extra 20%. All the plans that you're talking about who do not have the primary care and all the extra stuff that you're saying you're going to add is actually government plans. So the government now is not taking care of the stuff that the private plans that the majority of people have. But you want them to take away the private plans to give them another government plan that's not going to have the full coverage that they have already. So you can see the confusion that the doctors have.
I'll kick it off. Okay, well, as Ricky said, the community discussions, the technical discussions are taking place, and there are lots of opportunities to clear up confusion, and there will be a lot more opportunities to have closed-door conversations to clear up confusion. Because, as we said, decisions have not been finalized, and there are a lot of things to actually decide together. The issue about employers, because there was a lot to be said, I'm going to try to answer each one in turn. The issue regarding employers, as Ricky said, or Dr. Brathwaite quoted the current law, and currently it is by law anyone who is employing people here is required to insure people with a local insurer. That is a current legal requirement, and there is no reason why that legal requirement would change. With respect to what will be in the core plan, and we are pained also when future care recipients who need additional prescription coverage run out. We feel that pain as well. I'm the chair of the Health Insurance Committee that actually manages future care, and we despise that because we know it leads to complications and to higher costs elsewhere. So the whole point of this basic plan would actually improve the coverage under future care, and that is exactly the intent. A GHI patient who needs to find an extra 20%, I don't know where that comes from because GHI is comprehensive cover, so I can't comment on that without understanding more specifics about it. But the future care example that was mentioned is definitely a great example of why we need to improve the basic coverage, why a plan that needs to actually provide what patients need.
Good evening. You say that you would like to make the population healthier through preventative care or better care. I find that your plan is going to do the exact opposite. Instead of us being able to treat our patients and care for them and do the extra that we do every single day, we're going to be doing less because we are not going to be remunerated the way we were. Do you guys have any idea how much the physicians, dental offices, and anybody else does in pro bono work per year?
So I've actually, if you're finished, you know, I want to let you finish. I'm not sure if you're finished your question. So we've actually asked that of, so just to talk about the pro bono work, we've actually asked that of physicians to report that, and there hasn't been the ability to actually say how much that is. So I'm aware, and we are very actually respectful of that there is a lot of pro bono work being done, but how much is actually done, there's actually no reporting that it has been made available or can be made available, because we've asked, can you monitor and can you send us how much pro bono work that you're doing?
How many of us have ledgers that we can print out what is written off every year?
Easy. I can give you that tomorrow morning.
As I said, we're happy to get the reports because we've asked for them.
But we won't be able to continue
So,
doing this with your new plan.
Well, in terms of the new plan, as the PS has said, the finality or the decisions around remuneration around the plan have not been determined. So I don't know if we can actually form conclusions as to whether the revenue that you're making now and the revenue, if there is a decrease in revenue that will force you off island, will actually be affected, because we actually haven't gotten to the point where we made those decisions. So any assumptions about how much is going to be changed in terms of remuneration actually hasn't been determined. So I can't really speak on a practice-by-practice level as to how much that change would be, because that decision hasn't been made. What has been discussed to date has been a revenue neutral based on a number of codes that have been put forth, a revenue neutral discussion model for how we can move from a fee-for-service model to a more capitated model based on what the feedback you've provided as providers, saying that you'd prefer to have a model where you don't have to deal with so much insurance administration, where you can just do what you got into the field to do, which is take care of patients. So the capitated model, based on what you've told us so far over the last few years, is that you'd like to have a more simplistic model, so that's what we put forth at a revenue neutral dollar amount.
I think that you should ask the population, and I wonder what percentage would agree with you guys going forward with this plan. I think that most of us would not support it.
So I guess what aspect? So I do want to touch on that, because there is components of the plan that you're talking about, and if you were to say to the public that they are against prevention, I would say that they wouldn't agree. So to make a statement and say that the public would not agree with the plan, if you're talking about components around capitation, maybe you have a fair point, but to say in general the public does not agree with improvements in the healthcare system, I think that would be unfair. I sat in a room with a large number of individuals in a panel the other day, and the question was asked, do we need to transform the healthcare system? And about 95% of the people raised their hands, right?
Okay, one at a time, please. Finish. One at a time. Finish, Ricky.
So the question about not like this, we have not determined what not like this looks like, right? So I would hope that the conversations can be two-way, and we can come up with a solution based on the fundamental building blocks of the components of this plan, and come up with something that works for the future and a sustainable plan for everyone. This is a two-way conversation that we're having. There have been no final decisions made on this plan.
I'm just looking at the time. It's 7:38. I just want to give us a time check. I said that we're going to go to about 7:45. So we have time for one, maybe two more questions. Go.
Good evening. I just wanted to ask, at the moment I have a private insurance policy, and I understood from my insurer that I will now be required to have two insurance policies. And the MRF has gone up, so I'm trying to get some idea of what cost, and since we're actually all going to be required, if we want anything over and above the basic, we're going to have an additional policy. So do you have any idea of what those individual policies are going to look like? How we're going to manage that? Is that something I need to do? Is that something that is done by the insurance company? How how is that going to work, and what is that going to cost? Am I going to end up paying for your policy plus the MRF for a private one, plus the additional benefits for that? So I end up paying basically what I am now, possibly more. Thank you.
Thank you.
So the question came up in one of our community discussions, exactly that question as to how much will supplemental cost when you carve out some of the benefits that are currently in supplemental. That is in essence the question. So if you have 5 benefits that you're covering now, right now about 2 of those benefits. So just to be clear, and this has come up actually a few times recently, this concept of this is nationalizing, creating a nationalized health insurance, that is not correct. And this is not actually turning a current system where you have a legislative mandated minimum set of coverage now within your standard health benefit. This is not turning this into a socialized healthcare system either. And I know those 2 words have actually been thrown around a lot. But if you were to actually compare true national health insurance schemes and socialized system, you'll realize that this is nothing like any of those. This is taking a core set of benefits and regulating those benefits so everyone can have those specific benefits while there is a free market around the supplemental benefits. The question about how much will supplemental benefits cost, that can't be determined until you decide what the core benefits are, right? But so again, for example, and I'll use this example. If you have 5 benefits now in your current insurance package and you're paying $1,000 for it, let's say each of the benefits is $200, right? I'll try to make this pretty simple. So $200 per each of those benefits. Right now, 2 of those benefits within your package are standard health benefit. They're already regulated. All we're trying to do is say we're going to add 1 more benefit under standard health benefit and make that 3. Your question is, how much are those 2 other supplemental benefits going to cost? And our insurance company is going to raise the price of those 2 supplemental benefits that they're already covering because they no longer have the other 3 or the other 1 that we've added under their supplemental plan. That is a good question to ask insurers as to what is going to be their reaction when they're covering the same 2 benefits, but the other ones that we're covering under the Bermuda Health Plan actually are lower cost because we're regulating the price, but the insurance companies now have only the 2 benefits. Are they going to raise the price of those 2 benefits even though they've been covering them at a specific price all this time?
So, just to add to what Dr. Brathwaite said, because it is impossible to give an answer to that. What's going to happen to supplemental premiums after the changes? Well, we don't know what's going to happen to supplemental premiums from year to year. What we do know is that right now, the supplemental premiums vary tremendously by group, size, whether you're an individual, how old you are. So supplemental benefits don't cost the same for all individuals. It varies depending on a lot of things. And of course, when changes happen and these reforms take place, and they're going to be phased, everything is not going to be done in one fell swoop, then there will be an impact. We are hearing the concern from the public and taking it on board and thinking, okay, well, if supplemental premiums actually became extortionate for some groups of people or for the population in general, then that would be a deep concern and it would have to be addressed.
Can I address one?
Go ahead.
Sorry. There was a comment made about, in essence, if you have less benefits to cover, then you, in essence, have more overhead because you still have the same staff. The reality is that the majority of standard health benefit now are auto-adjudicated. There are no questions asked. There is no person that goes in and asks questions as to whether we need to pay the hospital for X service. These are all no questions asked, guaranteed payments that go through a computer and are paid. So to assume that there are a lot of people who are just right now taking care of standard health benefit would probably be a false assumption. If there are people who are watching the machines do the adjudication for standard health benefit, then we need to talk about efficiencies, right? Efficiencies of the workforce in some of these areas.
We've reached 7:45. I promised that we'll end on time. We started on time. And so I'd like to thank you for being here this evening. If you have more questions or would like to give further input, please send an email to healthplan@gov.bm. Ladies and gentlemen, thank you.